Just
We're
2 minutes
online
more.
now.
Okay.
Yeah, but we're online now. We're just a little bit early, so it's okay.
Okay.
We'll use that to get people to invite other people
Okay.
so that they can join us while we're there. But already we're online on Facebook. So I'm going to look and try and tag you before the time. Try to see if I can add you to the program. So let me go to the place where it's happening, which is on Monitor Healthcare
Okay.
platform. So yeah, so I can just add you so that will be on your page.
Okay. Yeah.
Okay, and then I will invite other people as well, while other can also share it.
Okay.
Or yeah. So where are we? It's still loading there. So, okay, so I found it now. Let me watch. Look for a way to share this. Sorry. Okay. In internet is slightly unstable, so it's flipping in and out, in and out, in and out.
That's our situation, honestly. We just have to manage.
So I will share this now. Let me share to you first to a page. So your page is what's your Facebook name?
Abdullah Olalekan. Abdullah
Okay.
Olalekan. Search Abdullah Olalekan, you see it.
Okay. So
I actually signed in with my Google account.
Okay,
But
welcome
that
viewers. If you're joining us, you're welcome. We're just trying to sort out, just to share this. You can share to people, let people benefit from this so that we have everybody enjoy this program. We're talking about suicide today, which is a very important topic. However, let me try and share the link to everybody so that we can also share it further. So let's do, sorry. Okay, I'm sharing it to everyone now. Okay, so, right, welcome viewers. Watch party, okay, spending. Okay, that's fine. It's telling me that there's a watch party going on now, so which is good. Now, so we want to welcome you to another episode of Monitor Your Health, a program where we enlighten the public on topical issues. Today, we have a very important topic. We'll be talking on depression. My name is Dr. Femi Ogunremi. I'm your host for today. I have with me Dr. Tajudeen Oladele, who is a psychiatrist who will be helping us with the topic today. Dr. Oladele, you're welcome.
Thank you very much. Happy to be here.
Thank you so much. You might need to speak up a little bit. So, do you want to introduce yourself to the audience so that they meet you?
My name is Tajudeen Oladele, a psychiatrist working in Northwest Nigeria.
Okay, thank you so much. It's a pleasure to have you. I know that you're a very busy man as well, but for you to give us the time to be here today, we really appreciate you. Now, we know that especially in this time of COVID and quite a lot of things going on, everybody's stressed. I think last week we did something on panic and on anxiety and stress and how it relates to our health. Now, we're stepping a bit further to just discuss possibly the consequences of all these stressors that is just all around us. So today we want to talk about depression. Please, what is depression?
Depression is primarily a mood disorder. It is characterized by a clinical condition where the individual has low mood. And to understand this better, we can say mood is something you define as the prevailing emotional state. Say, for example, how you see the individual in 24 hours. Some people are habitually cheerful. Some people will look gloomy. Some people will look steady. Some people will look unchangeable. So if you characteristically know someone that is always happy throughout the day, he's always flying around very happy, you say his mood is cheerful. So that describes his mood in qualitative and quantitative way. So, but we talk about depression when the mood is on the low side. The mood can be on the high side, but we're talking about when the mood is on the low side, which is depression. So it means the individual is down, the chemicals in the brain are down, and there are certain characteristics that you see.
Right. Okay, so basically our mood can be all over the place. Human being mood. So what you're telling us now is you have sometimes the mood is high when you're happy, and obviously that you can't sustain that for too long. I would have thought then it can come low. So at what stage really do we start thinking? Because I know sometimes somebody will do something to me and I feel like I'm not happy about it. And I'm not happy. I could be unhappy about it for, a length of time X. And then I'll then flip back, probably forget it and then move on. Does that mean I have depression?
No. The clinical definition of depression is the intensity of that mood changes and the quality must be sustained over a prolonged period of time. Precisely 2 weeks as defined by the International Classification of Mental Illness. It has to be sustained in intensity and quality over a duration of 2 weeks for us to say someone has a clinical depression. If you are irritable, someone has spoken to you or done something to you in a way that you don't like and you are reacting, that's a reactive, I don't want to say reactive depression, more like a reactive situation. You are reacting to that particular event at hand. That's not depression. Because say in about 10-20 minutes, it will be over and your mood will brighten up again. So that's not depression. But we talked about clinical depression when the quality and the intensity of the mood disorder is so low and pervasive and it is prolonged up to 2 weeks, then we say this is clinical depression.
Right. Okay. So the
10-20 minutes, it will be over and your mood will brighten up again. So that's not depression. But we talked about clinical depression when the quality.
Okay. So 2 weeks is the cutoff time that we're thinking of.
Precisely.
Okay. Yeah. Thank you so much. Now, what actually you mentioned something like, and it's as a result of certain things. So you were going to go into that before I ask further question. So what are the things that can actually make somebody's mood to be low?
Yeah, there's quite a lot of things.
So what are the causes?
We can look at, let's start from the risk factors before we look at the causes.
Okay.
Epidemiologically,
yes,
is a common clinical entity in the population. It is said that about 2 to 5% of the general population has this problem. And in fact, a study that was done by Seni et al. In 2008 quantify clinical depression in primary care setting to be 24.9%, almost 25%. The lifetime rate is put at around 10 to 20%. And I'm coming to answer your question, but I need to talk about this epidemiology so that the listeners can follow us properly. The sex ratio is 1 to 2, male to female ratio is 1 to 2, which means it's more common in female. The age range is between 35 and 45 years, but it's quite prevalent in the female sex. We also notice that it increases with age in the male sex in Nigeria, and the mean age of developing clinical depression is around that 30 years of age in Nigeria. This was reported by Gureje et al. In 2010. So looking at the risk factor, to answer your question precisely, the risk factor will include things like heredity. If one has family history of the illness, maybe either of the parents suffers from the illness, there's a likelihood that their son, their daughters can develop the illness in later life as well. Then if one has had adverse childhood experiences such as lack of parental care, loss of parents, alcoholism, if there's history of alcoholism in the family, abuse, then if there are personality disorders from individual concern, and if there are traits like anxiety, impulsivity, obsessionality, and neuroticism, things like this can predispose people to developing depression. Then social circumstances, say for example, if someone is divorced or separated, we notice that depression is quite common among them than those who don't have these conditions. Then apart from this, adverse life event has been reported by Raquel and Holmes. The first one they rated as severe is loss of a spouse. You know, so anybody who has lost a close one or somebody is very dear to them, they are prone to developing depression. And in fact, a study was done in the inner borough of London way back in 1979, where they discovered that women who had 3 children under the age of 11 years with poor socioeconomic condition, and they have poor support from their husband, they are likely to come down with clinical depression. Then people who have physical illness like Parkinson's disease, like stroke, like diabetes, myocardial infarction, like cancers, they've been associated with depression. And in fact, in some clinical psychiatric condition too, we see depression coming on as comorbidity. So now those are the risk factors that can make somebody to go ahead and develop depression. So what are the causes? Actually, for all psychological illness, the etiology, otherwise known as causes, they are not known. But a lot researchers have delved into those areas and try as much as possible to see what are those things that can actually predispose people to developing depression. So they look at things like biopsychosocial factors, and they talk about the importance of life events, which I've stressed. Say, for example, somebody who had gone through war situation, and he has said things that are not quite unpalatable, very repressing experience, very, very tormenting experience. The people like that can go ahead to develop depression in later life because those conditions are rather adverse. Then if you have psychosocial stressors, a good example could be unemployment, poverty. This can predispose people to developing depression. Then just like I said, loss of a spouse, disruption of social situation where there is strike, strife, war, marital or parental relationship when it is severe. Maybe the mother died in infancy or in adolescence. The child can go ahead to develop depression as well. Then negative people who develop negative view of themselves, they are prone to developing depression as well. Then we know I said initially that it's more common in female than male. Probable scientific explanation is because the female sex, they have a larger hippocampus than the male sex, so they're very emotional, and emotional issues are stored in the is a memory hippocampus, like a memory center that stores emotional issues. And so for women, theirs is larger than ours, so they more or less like repository of emotional things, so it's easier for them to come up with depression than the male sex. Then social factor like low socioeconomic condition can explain causation, and why depression is quite common, and is socioeconomic, people with lower socioeconomic status. Then the last one will be biological causes. There are actually things, agents that can precipitate depression. A good example is vitamin deficiency. People are lacking in B1, B2, B12, B6, can go on, if it is severe and prolonged, to develop frank depressive illness that is only amenable to these vitamins. Then people with endocrinological disorder like Addison disease, Cushing syndrome, hyperparathyroidism, hypoparathyroidism can go ahead to develop depression. Minute nutrient like magnesium, if it is deficient and prolonged for a long time, can actually predispose people to depression. We know that people who develop stroke, because stroke usually happen around the internal capsule bordering on the thalamus. So that can affect the limbic system, which is the seat of behavior. And so they can come down with depression as well. I think this summarizes the causes of depression.
Right. Wow. That's quite a number of things actually. Thank you so much for
Yeah.
enlightening us on this. And so what I think people might be thinking about is, okay, so yeah, the mood is low. We know why
Yeah.
it can be low. So how can they actually prevent this? Are there preventive measures? I mean, obviously we've heard about some vitamins like vitamin B. We talk about magnesium and things. Are there things that individual can be doing? However, before we do that, please, our viewers, please, can you share these videos? We encourage you to share so that other people can actually pick up from where we are. Right. So, are there things that people can actually, do to actually prevent it? Because so many things are around us, so many things are happening. And I'm wondering, even after this COVID, post-COVID, like one of the psychiatrists told us last week, that, because of the length of time involved in people, developing panic and things like that, or anxiety and depression and things, by the time this wave of COVID will be going, you might have a lot of work in your hands,
Yeah, definitely.
what can we be doing to actually keep
Yeah.
ourselves sane within the same level,
Yeah.
spectrum? Yeah.
Yeah, there's a lot that can be done. Let's start to look at it from diet, because there's a saying that we get diseases from virtually the things that we consume. So a balanced diet that is rich in the right amount of carbohydrate, protein, fruits and vegetables, uh, then a little bit of fat will do the body a lot of good. So we should run away from processed food and eat more of plant-based food. This will help us, it will help the body to recognize those foodstuffs and digest them appropriately. Then they will use them up rather than becoming obese with what we are consuming. So a proper diet can help to make the thinking process very light, and it will not be complicated by depression. The second thing we can also do is to choose a healthy lifestyle. A healthy lifestyle here, I mean, we will not smoke, we will not take alcohol as much as possible, we will exercise regularly. If we choose an healthy lifestyle like this, it does help, because most of these things are injurious to the body. In fact, there's been a publication that established a link between cigarette smoking and mental disorders. That people who smoke are likely to develop one form of mental disorder or the other. So I won't be surprised if somebody is smoking heavily and it comes down with depression. So as much as we stay away from from smoking, then we all know that alcohol is a CNS depressant, and that when people take alcohol and it becomes chronic, it is often complicated with depression. So it's better not to take, and if you must take, it should be reduced amount. Then regular exercise, we all know this is vital for well-being. Another thing we can do is to avoid stress as much as possible. Try to run away from things that you know that they are obvious stressors to you, because when they do, they break down the natural body response, and we just won't be able to cope. So it's better to try as much as possible to do away with things that are stressful to us. And if it's not possible to do away with things like that, we have to develop appropriate coping mechanism to deal with them. And a good example is relaxation technique. So we must try as much as possible again to avoid triggers, things that we know will bring us closer to a depressive state. We run away from them. Then we again must try as much as possible to get good sleep at night. And another thing we must do is that when we have anything that is heavy on our mind, we should try and do talk therapy. We call it catharsis. You talk to a close confidant, somebody you can trust. Speak to that person about the problem, see whether you can get a better support. And if there's any support system in the environment, we should try as much as possible to annex it. What I mean by support system is loyal friends, relative, workmates that you know they are very close to you. Sometimes when you sit among them and you relax, you feel free and it eases stress away. Then as much as possible, of course, if eventually somebody develops depression inadvertently, he should quickly go and see a physician so that they can prevent the thing from transiting to a much more uh, complicated disorder. I think that's by and large what to do.
Okay, thank you so much. Now, there are a few things that you talked on that in that chunk of discussion, and I probably want to drag us back a little bit because certain things are quite endemic in this area. In Nigeria, I know, well, thanks to COVID, because a lot of social activity, one way or the other, I won't say in that respect, there's a bit of a reduction. I know that people, it puzzles me in the evening how people drink alcohol in this country. I mean, I'm talking about in Lagos. You know, every evening you see people gathering. You know, some people it becomes an habit. Every evening they sort of just drink. They drink and drink, and they see that as a way of actually lifting their own emotion. You know, but when you mention here now that alcohol actually is depressive, I know that that might be an area in Nidos, you know, to how does it work? Can we throw more light at this for for our people so that at least that single act might be one that might save somebody from depression.
Yeah, it's all right. Thank you for that question. Generally, it is said that it's a known fact that alcohol in itself improves mood transiently. Then, with prolonged use, it causes depressed mood. So then again, we all know that alcohol has a lot of energy in it. It has so much energy that immediately you start taking it, your pancreas will have to find a way of dealing with those energy. And that's why you hardly will you see anybody that consume alcohol without having pot belly, because the fat will be stored in those areas. And you know that uh, belly fat is associated with increased incidence of cardiovascular disease, increased incidence of myocardial infarction, hypertension, and all sorts of cardiovascular disease. So even if it doesn't happen in the short term, in the long run, if the individual persisted, he will definitely come down with a cardiac morbidity. So I would generally advise people as much as possible to reduce generously or stop the consumption of alcohol for their own health benefit.
Thank you so much. And I'm just going to speak to the public. You know, the consultant has just told us as well, exercise is very, very useful. And when we talk about exercise, I believe we're just an isomeric exercise. Like you don't need to be a sprinter. You don't need to be, you know, to go and play hectic football. Mere walking, you know, 3 times, maybe 30 minutes, 3 times a week, that will help you in your mental health as well, with some chemical that is also produced in the body. So those are things, little things that you can get your hand into to help you beef up. Now, so if you have any question from the public, we'll be happy to answer questions. If you type questions in the comment section, and we'll be happy to answer your question while the consultant is still online. And even if it's offline, you can drop your question there. We pick it from there, and then we will run. So now, those I know you talked about, you know, depression in the spectrum of, I mean, in a range of age. Does it mean that a child cannot develop depression?
Not
Or
exactly. Not exactly. Anyone can develop depression. I spoke about the median age, most age that people develop depression. However, younger age group or older age group can develop depression as well. We've seen depression in a 9-year-old child, 11-year-old, or people who are much younger than that. It depends on the situation around them. So extreme of ages can develop depression as well.
Right. So if we have children developing, develop depression, what can the parent do? What do you advise the parents?
Actually, to start with,
yes,
the manifestation of depression in children are quite different from what you see in adults. So take for example, right, you are likely to start seeing them misbehaving. They start doing untowards things. They can be unduly irritable. They might not listen to instruction. They might be playing truancy at school. They might become a very difficult child, and they might have problem with authority figure, even at school or at home. So the thing to do is actually to observe the child. So start with talk therapy. Call the child and speak to the child. Try and find out what is it that the child is not happy about, and see whether you can address that, because it usually starts from mild to moderate and before it goes to severe. So if in that case the trigger is identifiable, the parent can go on and deal with it. However, if it becomes something that is becoming a problem and very difficult to control the child, I suggest that they need to see an expert, a child and adolescent psychiatrist, to help them address the problem.
Right. Okay, so that means that there are psychiatry experts in pediatrics, psychology, or is it psychiatric condition as well?
We call them child and adolescent psychiatrists.
Okay. Okay, so viewers, you can hear, so this is not a problem to adults alone. It could be something that will happen even in children. So there are telltale signs to keep an eye on, just like we've just been enlightened this evening. And then, so if somebody eventually develop, depression, what do they need to do? Or what? Or I know you said they should go and see a psychologist to come and see somebody. So what do you do from your end to them? How do you help them? What is there? What help is there?
Yes, definitely. We try and help in a lot of ways. Once they come to us, the first thing we do is to assess them. We do a clinical assessment to try and determine what type of depression are we dealing with. Is it mild, moderate, or severe? And what are the triggers? Because usually in a depressive cycle, if somebody starts a depressed cycle today, say in about 6 months at most, that cycle is exhausted. They might get well in the morning and start another cycle in the evening. But definitely nobody gets depressed all through life. It's in cycles. So you try and find out for how long has this been going. You make your assessment and you come to that conclusion whether it is mild, moderate, or severe, because that will determine what type of treatment you are going to offer that person. So from assessment, so if it is mild, for example, just psychological treatment, cognitive behavioral therapy, and exercise is enough. If the individual follows it religiously and he comes regularly to see the physician, he's going to get better, and there might not be need for drug use. However, if there's a serious adverse life event or there's a serious precipitant, it might be complicated and move on to becoming a moderate depressive illness. When it has become a moderate depressive illness, you need to do more than psychological treatment and exercise. You might need to give drug. Then try and find out whether there's any interpersonal difficulty in that person's life so that you can address it. Try and see whether you can get some support for the individual in the society or around people around him, or in his place of work. So you try and do things like that. If it is severe, That means there are features to suggest problem with thinking, problem with perception. So that means the individual has started misbehaving. So you need to put the person on bed, admit the person and try to administer not only an antidepressant, you must also give something to control all those abnormal behavior. Then you bring in the psychologists, they have their own role. You prescribe all those treatments like cognitive behavioral therapy, interpersonal therapy, family therapy, supportive therapy. We can go ahead and do some of those things. But to some extent, we also ask the psychologists to carry out some of those, therapy. Then again, we go further than that to try and see what is the stressor in the person's life, and it has to be addressed by a competent social worker, because that will have a positive impact on the patient getting well. So this by far what we do when they come to us.
Wow. Thank you so much. Now, there seems to be a lot there that can be done. Now, what
Yeah.
somebody, just like you said earlier on, our mood keeps going in and out of a particular cycle where sometimes you feel low, sometimes you feel okay. You go a bit below, you come back into the normal, allowable mood status. You go out, you come back again.
Yeah.
Now, if somebody dips into this depression, okay, if the advice is get help, let's say they do not get the help they need, how worse or how bad can it be? How bad can it be? Where can it get to?
It can be really bad. And I'll tell you why it can be really bad. There are three cardinal symptoms of depression. Three cardinal symptoms. There's the low mood, there is the anhedonia, which we call loss of interest in regular and pleasurable activity. And the third one is that the individual will have reduction in physical and mental energy. So take that for example, low mood. It means the individual will just be perpetually low, not interacting with people, withdrawn to himself. He finds it very difficult to utter words from his mouth. And maybe even if he's going to speak, he goes to speak in monosyllabic form. Come, go. You starting a conversation, you're not going to get a very rich conversation with that kind of person. Then the impetus, the energy to go to work on daily basis is out, because don't forget I said there will be a reduction in physical and mental energy. So to do anything is zero. And the things they love to do, say somebody who is a physician who loves to go to work on daily basis can't even step out of his bed. You just feel like sleeping on the bed all through the day. That's counterproductive. That's why I say it can get very worse. Then along with all these three symptoms, some people can now develop things like hopelessness. They can become very hopeless about this life. They can begin to say they are worthless. They can begin to entertain suicide. That what are these? There's no use for them in this world again. Why don't they just end it and go and live and go to the life beyond peacefully? So that's when they start contemplating suicide, and they might actually go ahead to commit that suicide. You know, and when a soul is lost, that's too bad. So it can get as bad as that.
Okay, thank you. So now, I want us to throw some light into this for our colleagues, colleagues, especially the general practitioners, because a lot of the time when a patient comes when they start getting into this low moods, there might be this sense of not even connecting with it, not even associating with the facts, and more so in our society where there's a lot of stigma around things like this. It might be a way where people might not, going to see a psychiatrist might not be the first step that they want to take, and it might be our colleagues in primary care that probably be catching this patient first. What are the words of advice? So how do you want to advise them when they see this patient? What should they be doing? How should they handle it?
Yes, thank you for this question. Four things I want them to put into consideration. I want them to double check to be sure that the individual has low mood. I want them to ask questions whether they can elicit anhedonia, loss of interest in regular and pleasurable activity, even if it is not intense. it's important that they elicit this. Then to go ahead and confirm that there's actually a reduction in physical and mental energy. And in most instances in Nigeria, when people come with abstractive symptoms, symptoms that you cannot please be careful. Try and ask around these things.
We're really struggling. Yeah, carry on.
Oh, hello, I said when people present with things that look rather abstract, they come and tell you something is crawling all over my body, they're somatizing their symptoms, something is moving in my head, we need to dig further. Usually those are signs of depression that have been prolonged with the individual, and the individual has actually translated them to bodily symptoms, and they are now presenting to the physician as if they have headache, they have leg pain. So we need to make sure that we double check that there has not been all these 3 cardinal symptoms of depression in the past. Once they do this, I'm quite sure that nobody will escape their clinic without being detected.
Okay, all right. Thank you. Are there, if I may ask, are there tools that they can use, that is already summarized this cardinal symptoms or parameters that they like in the UK, for instance, we use things like SATS person score. There's what we call the SATS person score, which we use to check for suicide intention in depressed patient and things like that. Is there something like that that we have or generated here locally that we can use?
No, I don't think.
Hello?
Hello, can you hear me? I'm on.
Hello?
Hello, I'm with you. Can you hear me?
Can you hear me?
Yes, I can hear you.
Yeah, I can hear you. Okay. Yeah.
So just like I said, we don't quite have our own local instrument. What we try to use is all these instruments that have been developed outside the country, but are now adapted and translated to local languages. So like the Hamilton depression scale, Beck depression scale. We also have them in rating scale. You can use them to make diagnosis, and you can also use them to rate those symptoms. They are widely available on the internet. They can download them. They are quite explicit. You probably don't need somebody to train you. You see those core symptoms there, and they tell you when the patient has so cut off so point, and then that means there's this, there's that. So you can actually use that to confirm or make it part of your assessment. They are quite possible.
We're struggling to hear you. The internet is really bad. All right.
But you can hear me, right? Can you hear me?
Okay. I can't hear you again, huh? Are you still there?
I'm there. Can you hear me now? Hello? Ade? Internet is low. Ade? Internet is low. Kí ló ṣẹlẹ̀? Internet is low. Is that what happened then? That's what happened. What could be the problem? Okay, you are back now. Hello, I can't hear him. Did you mute anything?
Okay,
you
can you hear me now?
Yeah, I can hear you.
Hello, can you hear me?
Yes, I can hear you now.
Can you hear
Sorry
me?
about that break. Yes,
Hello?
yes, I can hear you. Hello, I can hear you. I can hear you.
Yes.
I can hear you.
Okay, brilliant. So we're still online. We're still online. I think the internet is quite unstable. So we went off, it kicked us out a little bit, but we're back online again. So yeah, you were talking about, the instruments that are available locally and things like that, and then we were kicked off.
Yeah.
Or kicked out.
So I said most of these instruments are adapted from outside the country. They've been developed by clinicians, so we adapted them for our local use. They were translated to various languages and tested before we adapted them for local use. They are widely available on the internet, like I said. So they can actually type "I'm eating depression skill" or "beg depression skill." There are a lot of them, and they can download them, and they are quite explicit. Just like I said, you don't have to be trained. It's easier for you. They
Right.
tell you the cutoff point, and those core symptoms are there. So some are self-administered. You just give it the patient
Yeah.
to do, and some you administer. Interviewer administer. You actually administer it on your patient. So it depends on what
Okay.
the
All right. Thank you
physician
so
wants.
much. Yes. Yeah, thank you. Now, as we're rounding up, because we're almost 40 minutes into this summer now. So, as we're rounding up, what advice would I know that in Nigeria, when we look at psychiatric issue that like things like depression, other non-physical conditions, there's always stigma around it or around them. What's the advice that we want to give the public, and before we go there, what are the supports that the family can actually can offer in case of management of this patient? So what do you advise the family?
Yeah, well, my advice to the family would be that they support the patient as much as possible. Support him or her to take medication, to see the illness as less halting. Then, as much as possible, for the individual to be able to pick the pieces of their life and continue to do what they've been doing. So this is quite important. It's also important for the family not to take away the roles that those people have been playing in the family, and as much as possible, they should not stigmatize them at home as well, because very often they will say, no, you just came back from the hospital, don't do this, don't do that. That can be weighty on the patient. They should just allow them to live their life while trying to encourage them to live a normal life and take their medication, and I think they'll be good for it in the end.
Okay, thank you so much. So on this note, I think we will be rounding up now, and I just want to throw some words of support to what our psychiatrist has been talking about. We've talked about depression. Depression is quite common in our community, even though we assume that depression is not there, but it is there. It's just that possibly we're not familiar with the symptoms. And like any other illnesses, it's also an illness that needs dealing with. It's just like somebody has malaria. We've read today that our mood works within a tunnel, and it will keep going slightly low, slightly up, slightly low, slightly up. Sometimes we tip out of the tunnel. Maybe somebody gives you money, you're so happy, euphoric, and then you're happy that you can't remain there for so long. Obviously, within maybe a few hours, it comes down to normal, the reality of life.
Yeah.
And then you keep going, somebody kick your toe, then you become sad, you be a little bit depressed, and then you come back again into the tunnel. You keep walking within this tunnel. That's normal for us. But for some people, they remain down there for about 2 weeks or more, like we read today. Then we say that they're depressed. These are the people we're talking about. It's a horrible place to be. They're not happy. They don't feel. We've had so many things. So if you're feeling like that, it could be something related to our work. It could be something related to our family. It could be some, issues that need, obviously, ironing out. Don't continue like that, because the more you stay there, the likelihood that you get it to reverse. But the earlier you see somebody, the better. We heard today about the fact that you can have, psychological support. When you have a top therapist that they'll be able to discuss with you. You have to be open-minded. You'll be ready to talk about things, and they can explore things with you, and then look at an alternative way of doing things occasionally. And then if that doesn't work, there are other things that can be done. You see your own doctor. Your doctor identify things. There are tools that can be used with her today, and those tools are available online for general practitioners and for those people that also take care of people like this. You can look at it and see whether they're within the range where spectrum you can help them by giving them exercise, by giving them some, reasonable talk. And if that doesn't work, don't forget your psychiatrists are there. they will be happy to see these patients. And then they can start, initiate other treatments. Sometimes my involve, use of medications. And then you get your life back, and then we can keep moving. To know is the key knowledge that we need to have. When you do not know, or when you know and you pretend that you do not know, then you're deceiving yourself. Things will get worse rather than getting better. So our encouragement is that if you feel you have symptoms like this, try and see somebody, try and talk to somebody. I told during our previous episodes, I discussed about Area Doc, which is one of our, Area Doc is an app which you can download online. You can download it iOS or Android. You have free access to doctors. You can chat with doctors on initial phase about what's going on with you. You can also call a doctor and discuss. It's all free. They're not charging you anything for that. So if you feel it's you're not sure, you can also go through that route, and then you have free initial assessment from doctors. They can then tell you whether you need to see another doctor physically or not, and then you can then move things forward for yourself. There are a lot of challenging things in Nigeria, and we know that things, hopefully, we can only be hopeful that things get better. But in the middle of all these things, let's use the opportunity that we have. Dr. Oladele, thank you so much for coming today. We really appreciate you. We appreciate your time. Despite how busy you are, you're able to spare this time for us. Thank you so much.
Thank you for having me.
Yeah. On that note, I think we're going to end today's episode, and we look forward to meeting you again. I think we have another episode on Saturday where we'll be talking about, COVID-19 and how the community spread that we're having in the country, whether the country will need to lock down again, or we're still going to carry on the way we are. We have an expert, a professor of public health that will be coming to talk to us on that. So we look forward to meeting you then on Saturday. You can get more information on this if you just check my Instagram page, which is Dr. Femi Ogunremi. Follow me, you'll get some information on our latest topics. And you can also follow Monitor Healthcare Facebook, which is the one that you're watching this. Thank you, and God bless.